Hello friends, this is Dr. Vivek Goyal, your nephrology faculty. And the next topic that we are about to study is a very important glomerular disease which goes by the name of Membrano-Proliferative Glomerulonephritis. Now there are some misconceptions which let me clear out right at the very outset. You also know that there is a disease known as Mesangial-Proliferative Glomerulonephritis. Yes, but please let me tell you at the very outset, this is not equal to this. So remember, membranoproliferative is not equal to mesangial-proliferative glomerulonephritis. If you remember, as the name implies, mesangial-proliferative means proliferation of the mesangium. And in which disease did we study that there is a proliferation of mesangium? Yes, you are correct. It is IgA nephropathy. So it is the prototype of mesangial-proliferative glomerulonephritis is IgA nephropathy. And membranoproliferative is not equal to mesangial-proliferative. Membranoproliferative is also abbreviated as MPGN. So membranoproliferative is also known as what? If it is not mesangial-proliferative, then what? It is also known as mesangiocapillary glomerulonephritis or lobar glomerulonephritis. Very important. So it is mesangiocapillary glomerulonephritis or lobar. So you have understood that MPGN is equal to lobar is equal to mesangiocapillary glomerulonephritis, which is not equal to mesangial-proliferative. I hope I am absolutely clear. Now, MPGN is a pattern of glomerular injury on kidney biopsy. Now, it is not a disease entity. It's a histologic entity. Now, what do I mean by that? Say, for example, all of us have seen an ECG. Now, if I tell you the diagnosis of this person is ST elevation, you would start laughing. You would say, sir, ST elevation is not a disease. It's a pattern on the ECG. It can be found in AMI, it can be found in hyperkalemia, it can be found in pericarditis, it can be found in early repolarization variant and so on. Similarly, MPGN is not a disease per se. It's a histologic lesion and it is not a specific disease per se. So it is a culmination of a lot of diseases. What are they? That we will discuss. Now, MPGN will account for 7 to 10% of cases of biopsy-proven glomerulonephritis. I hope I am clear. Now, why do we say MPGN or membranoproliferative? So, we have understood that here you have two words. One is membrano and one is proliferative. So, M stands for membrano, P stands for proliferative, and GN is basically inflammation of the glomerulus. That is true for every GN. So it is IgA nephropathy also, it is for crescentic glomerulonephritis also, for any other glomerulonephritis. Okay. So membrano means there is thickening of the GBM due to deposition of immune complexes or complement factors with new basement membrane formation. So there is a membrano means thickened GBM due to deposition. Why did it get thickened? Because of deposition of something. And when it got deposited, it led to reduplication or formation of a new basement membrane. So it led to reduplication of GBM or formation of a new basement membrane. Now come to proliferative. Proliferative means increased in cellularity. Now there is cellularity increase in the mesangial or the endocapillary cellularity, often leading to a lobular appearance of the glomerular tuft. So say if the glomerulus was like this previously, then when it is MPGN, there is increase in cellularity and usually it gets a lobular accentuation. There is a lobular appearance as if the glomerulus has been divided into multiple lobes. And that is why it is known as lobar glomerulonephritis. See here, there is as if so much cellularity that it has been divided into multiple lobes and there is lobular accentuation. that due to proliferation. Now, when I said that there is membrane reduplication, so what you will find here is, if this is a capillary loop which is normal, in MPGN you get to see this because there is a reduplication of GBM due to deposition of immune complexes and inflammatory injury, and that is why this looks like a double contour, and that is why it is known as double contour sign, or this is also known as tram track appearance. Tram track appearance. So MPGN pattern on light microscopy, on histopathology examination, often yields a characteristic due to membrano. Due to membrano means thickening of the GBM and reduplication of the GBM gives rise to a double contour appearance or a tram track appearance. Double contour or tram track appearance. I hope I'm clear. And due to proliferation, it leads to a lobular accentuation. So we have already understood how will an MPGN glomerulus look like. So you will have a thickened GBM, you will have double contours, and the entire glomerular tuft will be lobular, and there will be lobular accentuation due to increase in cellularity. I hope I'm absolutely clear. So right from the name, we have devised how will be the morphology of the kidney in this disease. Now, as I already told you, the light microscopy features are increase in mesangial cellularity. There is cellularity increase in the capillary loops. So there is endocapillary proliferation, and there is capillary wall remodeling. So there is reduplication leading to double contours, all of which will leads to lobular accentuation. Now these changes, why do they occur? Due to deposition of immunoglobulins, complement factors, or both due to the injury. I hope I'm absolutely clear. We've already discussed this. Now, right here only I wanted to show you how does this look like. Now, if you have seen a glomerular tuft before, please see here beautifully, which is highlighted in the arrow. Just see this glomerular capillary. Can you see this? This glomerular capillary, you see there is doubling of the GBM. I will show you once at one more place. Definitely. Just see here. There are multiple. In fact, all the glomerular capillary loops have double contour. Just see. Had it been a silver stain, then it would have looked more beautiful, and because the silver stain highlights the basement membrane much more. So this CA is your double contouring or tram track appearance. Also, just see the entire glomerular tuft seems to be enlarged, and it looks as if there is lobular accentuation of the glomerular tuft. Yes, that is why it is known as a lobar glomerulonephritis. Also, if you can see there that some endocapillary loops are not patent. See, these are the patencies of the endocapillary loops. It can be found in some, but yes, some cannot be found. They're obliterated. Why are they obliterated? Because the endocapillary cells have proliferated and blocked the loops, the lumen of the loop. That is why, see here. That is why there is endocapillary proliferation, and also there is mesangial proliferation. So there is thickening of GBM, double contours, endocapillary, mesangial proliferation, hence MPGN. Now, how to classify MPGN? Now, when I was doing my MBBS and even my my MD, in the initial part, we were taught that MPGN is classified into type 1, type 2, type 3. Yes, you remember those MCQs which had appeared in NEET PG also. Type 1, type 2 and type 3 MPGN. So basically you got to remember that was the older classification, and that was based on electron microscopy. So why type 1 had subendothelial deposits, type 2 had intramembranous deposits, and type 3 had endothelial, subendothelial, intramembranous, or subepithelial. So anywhere, everything that was left out from type 1 and type 2 was put in the garbage of type 3. So that was the older classification based on electron microscopy. But it did not tell us anything about the pathophysiology, the etiology of the disease. That is why the current and the latest MPGN classification has discarded the type 1, type 2, type 3, and now we classify it on the basis of immunofluorescence, because it is a pathogenetic classification and not just a morphological classification. So that classification divides MPGN into immune complex MPGN, complement mediated MPGN, and third, neither of the above. So what do you mean by that? You have, please don't remember it by the name of 1, 2, and 3. That will be confusing. Again, because you can think about the overlap from the previous classification. No, just remember it. It is immune complex, it is complement mediated, and neither immune complex nor complement mediated. So immune complex can be caused by infections, autoimmune disease, malignancies. Complement mediated is of course caused by a certain disease entity, which we shall discuss in absolute details, the C3 glomerulopathy. And one which is neither immune complex nor complement mediated can be, say, thrombotic microangiopathy, could be transplant glomerulopathy, and so on, which we shall discuss. So you have understood the previous classification was EM, morphology based. Now we have IF, which is pathogenesis based. First we had type 1, type 2, type 3. Now we have immune complex, complement, neither immune complex nor complement. I hope I am clear. So the current classification divides MPGN on the basis of IF. This itself is a question. So now you will have, the first group will have deposition of both immunoglobulin and complement, because you have the immune complexes are formed by what? By immunoglobulins and complement. So here you have immunoglobulins plus minus complement. In the second part, you have only complement. And here you neither have immunoglobulin nor have complement. I hope I'm clear. Now, if you're talking about the first category, I told you it could be caused by infections, autoimmune disease, or monoclonal gammopathies. Or if no cause is found, that would be idiopathic. Coming to the complement mediated. If it is predominantly mediated by complement C3, that is known as C3 glomerulopathy. If it is predominantly C4, that is C4 glomerulopathy. And the third disease entity, where you neither have immunoglobulin nor complement, there could be thrombotic microangiopathy, you could have APLA, you could have chronic allograft nephropathy, you could have radiation nephritis, or you could even have malignant hypertension. And of course, transplant glomerulopathy, which is very, very important, and we have discussed it already. I repeat myself, immunofluorescence, immune complex due to infections, autoimmune, malignancy, idiopathic. Complement mediated, C3 mediated, C3 glomerulopathy, C4 mediated, C4 glomerulopathy. C4 is not important. C3 glomerulopathy is very, very important. We shall discuss it in details. Third, neither complement nor immunoglobulin. There you have the thrombotic microangiopathy, the transplant glomerulopathy, the radiation nephritis, the malignant hypertension, and so on, which is very, very important. We already discussed about the immune complex mediated MPGN. We have the infections. Among the infections, we have the hepatitis B, hepatitis C, HIV. We have the endocarditis. We have already discussed in endocarditis related GN, you could have an MPGN pattern. I told you. So here again, you can correlate. Next, again, the protozoal infections. Among autoimmune diseases, we know you could have an SLE, You could have a scleroderma or a Sjogren syndrome or even a cryoglobulinemia. Now, henceforth, when we shall discuss cryoglobulinemia, there I shall tell you the most common histopathological light microscopic finding is MPGN. So just see, when I am teaching you MPGN, I am teaching you the cause of cryo. When I am discussing cryo, I will tell you about MPGN, of course. Next, monoclonal gammopathies like MGUS, leukemia, lymphoma, myeloma, and miscellaneous causes, of course. Now, coming to MPGN. Now, you might be thinking that, sir, when you discussed about nephrotic syndrome, you discussed about minimal chain disease, FSGS, and membranous nephropathy. When you discussed about nephritic syndrome, the RPGN, you discussed about the post-streptococcal, the infection-related glomerulonephritis, the immune complex-mediated glomerulonephritis like SLE and others. You also discussed about the ANCA vasculitis and the anti-GBM nephritis. But you never told us much about MPGN. I didn't tell you because it is neither a nephrotic syndrome because it is neither a nephrotic syndrome, it is neither a nephritic syndrome because it can present to you as both nephrotic syndrome. So it is a basically overlap between nephrotic syndrome because it can present to you as a nephrotic syndrome. It can present to you as a nephritic syndrome, usually associated with hypertension, usually associated with systemic features because it is associated with systemic diseases. So there is often a presence of fever, malaise, weight loss, etc. Now, coming to the grave presentations, it could be associated with a rapidly progressive glomerulonephritis in 10 to 20% patients. And it is a bad disease because it progresses to ESRD in 10 years in about 40 to 50% of the patients. So it is quite an aggressive disease. So if today you have an MPGN, it is a 50% chance that in 10 years you will progress to ESRD and you would be requiring renal replacement therapy. So it is not a good disease to have. So it could present as a nephrotic syndrome. You could have a nephritic syndrome. Of course, you will be having raised creatinine in the laboratory tests. The urine will show proteinuria, hematuria, RBC casts. Of course, that is what you mean by active urinary sediment. Now, coming to the biopsy findings. Sir, biopsy findings, do I need to tell you? Because the classification itself started with the biopsy finding. So in light microscopy, what you will get, you already know. You will get lobular accentuation, you will get cellular proliferation, you will get double contouring, which we've already told you. Coming to immunofluorescence, again the classification. If you get predominantly immunoglobulin plus minus complement, you could get only complement deposition, or you can get neither of the above. And the last but not the least, EM. In EM again started with the classification. You could have subendothelial deposits, you could have intramembranous deposits, and you could have deposits anywhere also. So again, it's a very, very heterogeneous disease entity, as I told you, because it's not a disease itself per se. It's a pattern of disease. It's a pattern of glomerular injury. It's an MPGN pattern. So we have already discussed about the biopsy findings. And now, coming to the treatment of MPGN. Now, the treatment of MPGN would be, now, as you know that there are three classes of MPGN, the immune complex mediated MPGN, the complement mediated, which is the C3 glomerulopathy, which we shall discuss, and last is neither of the above. So both there are three variants, as I told you. One is the immune complex mediated MPGN, one is a complement mediated MPGN, and last is neither immune complexes nor complement. Now this we shall discuss later. Talking about the third category where neither immune complexes or complement are involved, again you need not treat actively. Usually you most often follow you have to treat the disease which has caused it. So if it's an APLA, you have to treat APLA. If it's a malignant hypertension, you have to control hypertension. Coming about the immune complex MPGN or the first variety of MPGN. Now again, immune complex MPGN, the treatment would be, first of all, treat the cause. So if you have an infection, Hep B, Hep C, treat it. If you have a paraproteinemia, myeloma or lymphoma, treat it. If you have an autoimmune disease, SLE, Sjogren's RA, treat it. But sir, if we do not get any cause, then that is known as idiopathic immune complex MPGN. Now this, you've got to know how to treat. So idiopathic immune complex MPGN, how can it present to you? Now if the patient has come to you with an advanced presentation where the EGFR is less than 30. So already the patient has come to you at a CKD G4 stage. Of course, will not hammer him with immunosuppressants, just treat him conservatively. Just expected management, nothing much. If the patient comes to you with a crescentic glomerulonephritis, that is, a patient has presented to you with an RPGN clinically. So a very rapid, robust presentation, history of small duration, patient has active urinary sediment, rapidly rising serum creatinine, and biopsy you see full of crescents. Of course, you have to treat him like ANCA vasculitis, as you treat any other RPGN or crescentic GN for that matter. You treat like ANCA, so basically you give a pulse methylprednisolone and you give cyclophosphamide or rituximab. Now, what if the patient presents to you with a subnephrotic proteinuria and the GFR is stable? So it's a very milder presentation. So you've got to know that there is not much of a glomerular inflammation happening here. Here again, you treat conservatively. Do not do much. So just control the blood pressure, give ACE inhibitors, ARB, and watch how the disease behaves. But if the disease presents to you like a active disease, so not like a crescentic GN, but there is presence of activity. How? You have active sediments in the urine. You have proteinuria, which is massive, more than 3.5 grams per day. And you have the GFR is declining. So the serum creatinine is rising. There is hematuria, active RBC casts. There is proteinuria, which is massive. Then you have to give immunosuppressant. There, what will you give? You will start the patient with steroid and plus minus MMF or cyclophosphamide. If this does not work, of course, you have your Brahmastra, not the movie I'm talking about, but the rituximab. So this is how you treat your idiopathic immune complex MPGN. I hope I am clear. So the idiopathic immune complex MPGN, you have to give, if the patient has an advanced disease, conservative. If the patient presents like crescentic or RPGN, treat like ANCA. If the patient has subnephrotic proteinuria, normal GFR, again, conservative management. But if the patient has active disease in the form of rising creatinine, hematuria, severe proteinuria, then give immunosuppressive therapy. So this is about membrano-proliferative glomerulonephritis. We have purposely not discussed about the complement-mediated MPGN, which is the C3 glomerulopathy, which we shall discuss in the next module. Thank you very much.